And thanks so much for joining us, Dr. Hong.
Awesome. Thanks for having me. Let me share my screen. No, I think that's wrong. Okay, can you guys see my slides appropriately?
Yeah, looks good.
Okay, thanks. Thanks for having me. My name is Jeff. I'm a third-year pediatric cardiology fellow here at Children's National. Going to be graduating in June and then doing a fourth year in EP. This is my first time kind of presenting to non-residents and non-fellows, non-medical students. So happy to hear any feedback. And I didn't really do a dry run of this because I'm hoping to get a good amount of participation. We may or may not be able to get through everything in the hour. No disclosures. So I thought I would just start with some cases that we could talk through. So the first case, and there's going to be a lot of variations on these cases. So the first case is a 4-month-old female who's doing well, was just seen to have a heart rate of 280 beats per minute at our well child check with her pediatrician, who sent her straight to our ER, or I guess not to our ER, maybe to an outside ER. She's a little fussy, but consolable and is alert and feeding pretty well. And so the ER gets an EKG. And this is what it looks like. So what do you guys think about the ECG in general? Feel free to throw any thoughts out there.
I was going to go with SVT. It's just that's the way it looks. It's rapid. Or could we just sort of...
Yeah, absolutely. I would agree. You know, the heart rate is around 300, which is what the pediatrician reported, right? So it's not like there's some artifact there's something that was miscounted at the pediatrician's office. The heart rate is very rapid. You know, it's hard to tell if there's P waves here in the leads. I will say in a 4-month-old, sinus tachycardia up to 280 would be very unusual, right? Usually by 4 months, your peak heart rate in sinus rhythm is probably around 220 to 230. So once you're getting above 240, it's almost certainly some type of arrhythmia. And it's also pretty difficult for VT to get up, ventricular tachycardia to get up to a rate this high. So SVT is your most likely bet. And then I do think if you look in lead V2 here, you can see these kind of notches in the ST segment. It's pretty clear there's like a notch right there. And that, I think, you know, is consistent with retrograde P waves. And so that is, it makes it kind of points us towards the specific type of SVT, which is probably a AV reentrant tachycardia. But regardless, you see this, you call it SVT, which I would agree with. What are you guys thinking in terms of management or assessment or I guess assessment first for the patient and management?
I mean, off the top of your head, stable or, you know, kind of stable or unstable. Look at the basics, get a full set of other vital signs, pulse ox, blood pressure, things like that.
Absolutely.
Mental status, level of consciousness, and then trying to find a timeline too for like how long she's been in this. And I'd also want to know if they got like a chest x-ray to assess like any signs of, you know, congestive heart failure or signs that this has been going on so long that she's starting to, you know, turn the corner for the worse.
Right, you're absolutely right. Yeah, so SVT in general is very well tolerated in babies, up to hours to even, you know, a day or so. And sometimes, and in those cases, if they've only been in it for, you know, let's say 6 hours, they probably won't have any symptoms. The chest x-ray would look normal. You wouldn't see any pulmonary congestion on the x-ray. They would still be feeding fine, maybe a little fussy, but still consolable. SVT that's gone on for days, that can eventually lead to heart failure. And you would see, you know, cardiomegaly on the x-ray, you would see poor perfusion, you would see, you know, poor feeding, altered mental status. And so stable, unstable, great point. So in this case, the baby was stable, chest X-ray looked fine. What would you do to try to break it?
If you're able to, some sort of vagal maneuver on a 4-month-old, if you're able to be successful, but then outside of that would be next message would be medication with preferably adenosine trying to break it.
Perfect. Yeah, adenosine is what I would go with as well. In a 4-month-old, it's hard to do vagal maneuvers. When you have a teenager, you can have them blow in a straw or kind of bear down. In a 4-month-old, really the only thing you can do is, I think, ice to the face. And I found that that's usually not been very, very effective and just pisses the baby off more. And so you can try that. And then typically, if that doesn't work, I go, straight to adenosine. Does anyone know the dose of adenosine off the top of your head? You don't have to. It's in the PALS,
0.1, 0.2, 0.2.
Yeah, 0.1 is the first go-to.
For adults, 6, 12, 12.
Yeah, perfect. So you give adenosine, and this is what the strip looks like during adenosine administration. It's very helpful that the ER actually marks where they gave the adenosine, and you can see actually the heart rate actually slows down first, slowing down the AV node, and then there's an abrupt termination. And the baby's pretty wiggly here, so it's hard to tell really if you are truly in sinus. There's probably some degree of AV block still in this part of the strip because adenosine causes essentially AV block, but at least you're no longer in the SVT. Okay, perfect. So we'll go on to case 1B. So exact same history, same 4-month-old, same heart rate of 280. Still looks well. Comes in to the same outside ER, and they get an EKG, and it looks like this. And so, what do you guys think about this one?
That looks more like a wide complex tachycardia.
What else? Rate is still about the same, right? It's pretty high, probably 280 to 300 on this ECG. So what's your differential when you see a more wide complex tachycardia? Oops, go back.
Well, it could be like a VTAC. It could be
adult ways you treated taught VTAC, SVT.
Yeah.
Kind of the way to do it.
Yeah,
So,
absolutely. Yeah. Yeah.
But you could have a rhythm with like a rapid ventricular response too. Would that present in the same way? I mean, I'm thinking because it's so wide that it's originating in the ventricles, but that could be wrong.
Yeah, absolutely. So whenever I see a wide complex rhythm, I agree with you. I think ventricular tachycardia until proven otherwise. And it would not be wrong to treat this down the VTAC pathway with like lidocaine is, typically what we would use in the pediatric population. We'll talk about lidocaine versus amiodarone later on. The rate, when I look at this, the rate is very high. 280 is very rapid for even VT. A baby with a VT rate of 280 is probably not going to look very stable. And so certainly if the baby's unstable, you're going down the CPR pathway with lidocaine, epi if you need. But the other, possible causes of a wide complex rapid heart rate like this could be SVT with aberrancy, or a specific type of SVT in Wolff-Parkinson-White when you're going down the accessory pathway. And we'll talk about that in a second. But my question for you is, given this ECG, would you give adenosine? And this might be hard to answer.
I wouldn't at first. I would either, depending stable or unstable, I would either do lido or electricity.
Okay.
I would potentially consult cardiology because she said that she was, fussy but feeding. So
yeah. Okay.
But potentially giving adenosine to kind of slow down the rate at least to kind of see what's going on, get kind of a clear snapshot sort of after that.
Okay. Good thoughts. This is very tricky, especially, at certain ERs where there's perhaps not as much access to calling cardiology and having an answer right away. I think if you're in a position where the baby is stable and you are able to consult cardiology and get an answer, within minutes or, 10 minutes, and the baby looks okay, I think it is reasonable to try adenosine in something like this. And I will tell you later on kind of what my algorithm is for deciding whether or not I'm willing to try adenosine. Okay. But this, in a regular wide complex tachycardia, it is reasonable to try adenosine. And if it's SVT, you might break it. You might also slow the rate down, like you mentioned, Danny, and which will help us kind of diagnose what the issue is. If this is a ventricular tachycardia, right, remember the mechanism of adenosine is to act on the AV node and block activity in the AV node. And so if it's a ventricular tachycardia and you block the AV node, nothing's going to happen, right? The ventricular tachycardia is still going to just continue to run. And so if you give adenosine and nothing happens, then the options are, it was an SVT that didn't respond to adenosine, or it's just ventricular tachycardia. So this is the same case, so that wide complex tachycardia, they did give adenosine. And so the question for you guys is, did adenosine work, quote unquote? And so if you guys can see here is where it kind of breaks. So I'll zoom in there. Right.
So is this this is like a straight run? This is the same lead?
This is the same lead, yeah, a single
Okay.
lead. And let's say adenosine was given right in at this time point right here. And after adenosine is given, you see this rate slow down, right?
So it
But
slows
then-
down and then it speeds right back up.
Right. It jumps right back into the arrhythmia, right?
Yeah.
So let's say you gave 0.1 milligram per kilogram of adenosine in this baby. What would your next step be?
Double it.
Yeah, so that's a common thought, and it would make sense, I think, to try to double it. But the truth is, there's really no point in doubling the adenosine dose. The whole purpose of
didn't work.
adenosine is to just stop the AV node temporarily, and you've done that successfully with your adenosine dose of 0.1. Let's say this strip, you don't see this strip, and let's say you give adenosine right here, 0.1 milligram per kilogram. Can everyone see my mouse, by the way?
Mhm.
Okay, let's say you give adenosine right here, 0.1 milligram per kilogram, and you give the adenosine and you see that absolutely nothing happens. In that case, look at, how you administered adenosine, make sure, it was in the largest IV possible and the antecubital fossa, right, closest to the heart, flush with a saline flush after. And if you think, you did all those things right, and that 0.1 dose didn't work, then it would be appropriate to double your dose to 0.2. If, however, you have this situation here where you see the heart rate break, you know that the adenosine has worked. And so there's no reason to give a bigger dose or really additional doses of medicine. Really what this baby needs is some kind of antiarrhythmic on board already, right? This baby you're able to get the baby out of SVT, but she just jumps right back into it. So in this case, it would be, things we would think about would be, starting an esmolol infusion or starting a procainamide infusion to get kind of a baseline antiarrhythmic in the system, that drip, have it on board for 30 minutes or so, and then give another dose of adenosine, and hopefully you'll break it and the baby will stay out of SVT. Adenosine is typically thought of as a benign drug, but there are risks associated with it. Every time you give adenosine, you do temporarily stop AV conduction altogether. And so you can precipitate, for example, you can allow PVCs to jump in and precipitate a ventricular arrhythmia. Adenosine also can cause significant bronchospasm. And so especially patients, a 4-month-old probably doesn't have asthma, but, in a 2 or 3 or 4-year-old or some older patients who have bad asthma, giving adenosine can really precipitate an asthma attack. And you have that to deal with as well on top of your arrhythmia. And so you really want to give, you don't want to unnecessarily give higher doses of adenosine if you don't need to. Okay.
Can you talk briefly real quick, because you just brought both drugs up, procainamide and
Mhm.
esmolol, in terms of infusion medications.
Yeah.
Can you talk briefly, because I've had 2 different SVT cases in the last 6 months where one used esmolol, the other one used procainamide.
Yeah.
Is it like draw the cards who's on service for the day, or like is there a little bit more specificity to the choice between the two?
Yeah, I mean, it is to a big degree dealer's choice. I think if the baby, beta blockers, the main thing we watch acutely for is bronchospasm. They can both cause hypotension. They can both cause decreased cardiac function. That's really a risk of essentially every antiarrhythmic except for maybe digoxin. So you have to watch them closely. But beta blockers, maybe if it's an asthma patient, we might go instead for the procainamide. But a lot of it can be dealer's choice. Esmolol is, we think of kind of as like a smaller gun medication, so I think that's probably why that one is more often used. Okay, so let's say, we got esmolol on board, then we gave the adenosine again, we broke the SVT, and this is what the ECG looks like after termination of the SVT. Anything jump out to you guys here? Here you can see the QRS is pretty wide, right? Still, and you do see P waves, but the PR interval is very short. And so there's kind of a slurring of the QRS, which is why the QRS is wide. And so a delta wave is kind of the buzzword, a delta wave with a short PR interval. What is that? Whoops. Back. So this is the classic EKG for someone with Wolff-Parkinson-White, or WPW. And we'll go, I'll have slides later to kind of describe exactly what WPW is and why it can cause tachyarrhythmias. Okay, so case 1C, so same 4-month-old female, same heart rate of 280, looks okay, sent to the ER, and this is your EKG. What do you guys think about this one? So wide complex or narrow complex? What do you guys think?
I'm still going to go with wide.
Yeah, I
Okay.
think wide.
Yeah, I would agree with you. What is different between this one and this one here?
Like regularity.
Perfect. Yeah. Yeah. So
This
if
one's
you
like a
look
little more wide and irregular.
yeah. So here at the bottom, you have a lead to rhythm strip. And if you just look at the R to R interval, it does look like there's some irregularity to it, right?
Yeah.
You could almost say it's a quote unquote irregularly irregular rhythm. You guys have heard that description, right? It's not a irregular rhythm that you might see with like, normal sinus arrhythmia, but kind of an irregular rhythm without any really pattern to it, right? It just is spotty throughout. And it's wide complex. And so we got a question up here as well. Would you give adenosine in this situation?
Is the patient stable or unstable?
Patient is stable.
I guess
Tricky.
I'm going to just guess and say you could consider it, but I'm not.
Okay. Any other thoughts?
I'm not sure.
There's only 2 choices. So this is an example of
Josh says no emphatically.
no. Okay, perfect. Who? Oh, I see a chat. Let me pull up the chat. Okay. Yeah. So this is an example of pre-excited atrial fibrillation. And this, if you give adenosine, you do risk precipitating ventricular fibrillation, cardiac arrest. And we'll talk about why later on. But the key detail is that it's in irregular rhythm. And that's what kind of tells me that I should not give adenosine. Okay. Try to go forward.
So in regular rhythms, whether they're fast, whether they're wide or narrow,
Yeah.
feel free to give adenosine because it's probably pretty safe.
Worth a
Always
shot.
a potential risk for some VF.
When you give adenosine
but
to anyone. Yeah.
most likely pretty safe. If it's irregular, then hard stop.
Yes. Perfect.
Cool.
You basically summarized my next 5 slides. So, just a little bit about terminology, because I do think it's important. And, you guys work with cardiologists. I think, cardiologists, I think, really love to be technically right, even if technically right isn't necessarily the most helpful in the situation. But when we in cardiology talk about the term SVT, we're really referring to anything that originates above the ventricle. So that is a whole host of arrhythmias, right? So there's AVRT, or AV reciprocating tachycardia, and WPW is a subtype of it. In pediatrics, it's a big subtype. It's honestly maybe the majority of it. There's AVNRT, there's ectopic atrial tachycardia, multifocal atrial tachycardia, flutter, fibrillation, including pre-excited AFib. That was this EKG here. And pre-excited AFib is a subtype of atrial fibrillation that only occurs in patients with WPW. Even junctional ectopic tachycardia is technically an SVT. Sometimes if you really want to be pedantic, you could argue that sinus tachycardia is an SVT, right? Because it originates from the sinus node, although that's probably, just again, a technicality and at this point. And at that point, meaningless. I think when the rest of the world, the general physician, the EM physician, transport team, when anyone else says SVT, what they typically mean is AVRT or AVNRT. And in pediatrics, that's probably okay because these two SVTs account for probably 90% of all SVTs of all of these in the pediatric population. But this differentiation is important because these two SVTs are the only two types of SVT that can actually be terminated by adenosine. The rest of these, adenosine, you may give it and you'll see a temporary AV block, and you'll see slowing of the rate. It may help you differentiate what's actually going on. It may help you with a diagnosis, but adenosine won't terminate any of these other tachycardias. Really, it's only AVRT and AVNRT. And since they're, the majority of SVTs in pediatric population, generally it's safe to give adenosine, although we'll talk about specific scenarios where it's not. And the challenge is sometimes it can be tell what specific type of SVT is present, right? A lot of times it's actually helpful to describe the tachycardia, like Danny mentioned, rather than knowing what exactly the tachycardia is, right? If I get a call from like an EM physician and they say, hey, we think, I've got this 4-month-old, we think he's in SVT, can I give adenosine? I would probably pause and say, hey, hold on, can you send me the strip? Can you send me a picture of the SVT? And then I'll tell you if you can give adenosine. But if you give me a call and you say, hey, I've got this 4-month-old who's stable, who is in a narrow complex regular tachycardia at a rate of 280, can I give adenosine? That's a perfect description, I would say. And you didn't even diagnose the specific rhythm, right? You just said narrow complex, regular, and the rate. I would say, that's a perfect description. You can give adenosine. I don't even need to look at the strip realistically, right? And so tachycardias can be narrow or wide complex, and they can be regular or irregular. So we've got 4 boxes, right? One of each. So which of these would you say is kind of the most kind of take a deep breath, the patient's probably stable, you don't have to act super urgently, finish your coffee before you see the patient? Which of these 4 boxes?
Narrow, complex, regular.
Yeah, perfect. Narrow, complex, regular tachycardia, right? So I'll give you guys some examples. So I think this was from the first case, right? This is a narrow, complex, regular tachycardia, looking at the R to R intervals. So we agree it's narrow, the QRS is narrow, and if you look at the R to R intervals, pretty even throughout, right? This is another example of a narrow complex regular tachycardia, right? Narrow QRS, R to R is pretty even throughout. And why is the description so important? So if you tell me that the tachycardia is a narrow complex regular tachycardia, it really gives a lot of information. It tells me that the tachycardia is originating from above the ventricle, right? So it's an SVT and it's not a VT. VT by definition is going to be wide complex. It tells me the patient is likely to be stable and remain stable. It tells me that adenosine will probably, especially in pediatrics, adenosine will probably terminate the arrhythmia, and adenosine is generally safe to give. There's always kind of the, caveats anytime you give adenosine to anyone. So watch out for prolonged pauses, PVC-induced arrhythmia, bronchospasm. But generally, patients tolerate it pretty well. Okay. All right. So out of these 4 boxes, which one is kind of the most urgent? Butt clenching. Oh, I got to have hands in the room. People aware of what's going on. Which one of these?
I'm going to go with irregular wide complex.
Perfect. Irregular. Oops. Irregular wide complex tachycardia, right? So this was an example that we saw in the case. There's another example, right? This one, sometimes the irregularity can be a little subtle, but this is for sure wide complex, right? And if you look at your rhythm strip, the R-to-R interval is, again, irregularly irregular. Here's another example, wide complex tachycardia that's irregular, right? And I want you guys to kind of sear this in your brain because this is the exact type of arrhythmia you do not want to give adenosine for. Here's another example for good measure. Another irregular wide complex. This is a case that we had several years ago. It was a regular wide complex. This same patient, adenosine was given, and the next thing you know, the patient's in ventricular fibrillation. And there have been multiple case reports, in the literature about adenosine being given in these situations and precipitating ventricular fibrillation. So again, when you tell me it's wide complex, when you tell me it's irregular, it tells me a few things. One, it's really polymorphic VT until proven otherwise, is what I would treat it as. It could be pre-excited atrial fibrillation, which is technically a type of SVT. I'm worried that the patient could be unstable. And even if the patient is stable, there's pretty high risk of becoming unstable. And adenosine will not terminate the arrhythmia and is not safe to give. And if the diagnosis is pre-excited AFib, then adenosine can precipitate ventricular fibrillation. Okay. All right, so we'll go through the other 2 boxes, right? So now we'll go to wide complex regular tachycardia. So here's an example, right? Wide complex. And if you look at the rhythm strip in lead 2, it's regular. This is just the artifact from the patient hiccuping or something, and it's regular throughout. There's another example of wide complex regular tachycardia. I actually think this one was probably VTAC, if I recall correctly, and not SVT with aberrancy, but that's okay. Really, the description of wide complex regular is what's most important. So wide complex regular, what tells me? Again, ventricular tachycardia until proven otherwise, but it could also be SVT, with aberrancy. Tells me the patient is probably stable, but monitor closely. Keep an eye on this patient a little more closely than the narrow complex regular tachycardia. Adenosine might terminate the arrhythmia if it happens to be SVT, and it's generally safe to give. Okay. And then the last one is narrow complex irregular. And so I'll give you guys an example. Here's a narrow complex, right? So the QRSs are narrow, but it's irregular. So this is the classic EKG of atrial fibrillation, which is much more common in adults. You guys will probably, if you guys, in older adults, this is very common. This is not pre-excited AFib, but just kind of bread and butter atrial fibrillation. And again, because it's narrow complex, it tells me the tachycardia is coming from above the ventricle, so it's an SVT. The diagnosis is likely AFib. There's a few other less likely diagnoses, such as ectopic atrial tachycardia with transient sinus capture, kind of zebras. With narrow complex tachycardia, the patient's probably stable. You know this is not AVRT or AVNRT. So you know that adenosine will not terminate the arrhythmia. There's a 0% chance. And, you know, adenosine might be safe to give, but it's not worth the risk. You're giving a medicine with zero benefit with potential risk. And so just to word it one final way, right? Narrow complex, right? If it's narrow complex, then I know it's an SVT. If it's wide complex, I know it's a ventricular arrhythmia until proven otherwise, but it still could be an SVT. If it's a regular tachycardia, like Danny said, it's okay to try adenosine, especially if the patient is stable. If it's an irregular tachycardia, adenosine cannot help and can only hurt. All right, so quick review of WPW. The classic ECG in WPW is a delta wave. So you have your P wave, which represents your atrial depolarization. Your QRS represents your ventricular depolarization. And you have a very short PR interval. So the ventricle depolarizes early for some reason. And you have this slowed up stroke called the delta wave. Right, so typical normal heart conduction starts at the sinus node, goes down the AV node into the ventricles. That's what gives you your narrow QRS. In patients with in patients with WPW, there's an accessory pathway, and conduction actually can go down the accessory pathway before it goes down the AV node. And so the ventricle depolarizes early. That's why your PR interval is short. And the ventricle depolarizes both from this direction and from this direction. And if you imagine if the conduction went down the AV node, then it would travel to the right ventricle and left ventricle at the same time. So the two ventricles kind of squeeze and depolarize at the same time, and that's why you get a narrow QRS. If it travels more, if the conduction travels more down the accessory pathway, in this case, the accessory pathway is on the left side of the heart, the left ventricle, you would imagine, would contract first, right? And then the conduction would go to the right ventricle, and then the right ventricle would contract second. And that's why you get a wider QRS, right? There's a kind of a delay between when the two ventricles seek electrical activity and then contract, right? So here's normal activation. Here's your WPW pattern with a short PR slurred up stroke. So there's different types of SVT and WPW, right? There's orthodromic. This is the most common by far type of SVT, right? So what happens is the conduction goes down the AV node. All of the conduction from the atria goes down the AV node, right? The left and right ventricle depolarize at the same time, so you get a narrow QRS. Then the conduction goes up the accessory pathway and is trapped in this loop. And this rapid loop produces your rapid heart rate and your SVT, and you don't see a P wave before the QRS. A second possibility, this is less common, is AVRT, that in which the conduction goes down the accessory pathway. If it goes down the accessory pathway and up the AV node, right, the left ventricle will see activity first, and then the right ventricle. And so you'll get a wider complex SVT, right? This is one of the reasons why you can have a wide complex regular rhythm, which on the surface looks like it's ventricular tachycardia, but is actually SVT. And in this case, if you give adenosine, right, adenosine breaks conduction, temporarily breaks conduction in the AV node, you break the circuit and you terminate the arrhythmia, okay? Third type of arrhythmia is pre-excited atrial fibrillation. So this is when you have chaotic activity in the atrium, Some of those impulses are conducted down the accessory pathway. Some of those are conducted down the AV node. And so you get this irregular rhythm that's wide complex. Patients with WPW are at baseline more likely to have atrial fibrillation than patients without WPW. What happens when you give adenosine to patients with pre-excited AFib? So if you imagine chaotic atrial activity, some of it's going down the AV node, some of it's going down the accessory pathway. You know, the property of the AV node is that it acts as a gatekeeper, where if your heart rate is fast enough, your AV node will actually block certain impulses and not allow them to conduct down the ventricle. It's a unique property of the AV node, and it does not exist in accessory pathways. We call accessory pathways like stupid. They don't, you know, they don't gatekeep any potentials. So you give adenosine, you block the AV node. You can force all of the pre-excited atrial fibrillation impulses down the accessory pathway, and the accessory pathway does not gatekeep. So everything that it sees, it lets go through. And so you can turn basically atrial fibrillation into VFib and precipitate a cardiac arrest. Anybody have any questions on that? Hopefully that makes sense.
Yeah, no, that's a really good descriptor to kind of explain that patho.
All right, perfect. Okay, we're gonna go to a second case. 16-year-old female who collapsed while playing a soccer game. You know, you guys probably saw the football player, I think, happened to a couple weeks ago. Team trainer started CPR immediately. AED has replied, and the AED shocked the patient. Second shock was delivered at EMS arrived, who continued CPR and achieved ROSC in transit. All right. So what stands out to you guys about this story here?
Witnessed with the shockable rhythm.
Yeah, perfect. Do you guys know the sensitivity and specificity of an AED shock? So let's say you hear that the AED shocked the patient. What is the true likelihood that the detected rhythm was a ventricular arrhythmia? It's on the order
pretty
of
high.
70 to 90%, depending on the AED. Yeah. So if the AED shocked the patient, it's an arrhythmia. There's a 90% chance that it was VFib or VTAC. Right. The other thing is, event occurred while playing soccer during activity, which is one of our red flag warnings for something that's caused from a primary cardiac issue. So we achieve ROSC. This is what the ECG looks like after getting ROSC. Any thoughts on this? Particular leads V6, V5. You can see the QRSs kind of crash into each other, right? The voltages are so high, right? And if I told you guys this patient had a harsh systolic ejection murmur in the aortic valve or left ventricular outflow position, what would you guys think?
Like a cardiomyopathy.
Yeah. So hypertrophic cardiomyopathy. This was actually formerly termed hypertrophic obstructive cardiomyopathy. You guys have heard HOCM probably. Really, we don't call it HOCM anymore. We just call it HCM, because the truth is cardiac arrest and sudden death can occur really in the absence of any true obstruction. Part of a major issue is there's, the myocardial, the heart muscle fibers are just in complete disarray. And so there's a lot of conduction disturbances, which can progress to an arrhythmia. And then exercise increases this because you increase your myocardial demand. If you do have obstruction, you are at a higher risk too, because with the obstruction, you lose perfusion to your coronaries as well. But arrest can precipitate without obstruction as well. Okay. So what do you guys think about in terms of management considerations? Oops.
It's probably going to be a pretty sick transport.
Say that again.
So it's probably going to be a pretty sick transport.
Yep.
I'd be worried that like we have a high probability of rearresting, that our heart's kind of pretty weak, and that any kind of changes in fluid balance and positive pressure ventilation and things like that could have pretty significant effect.
Yeah, absolutely. I would think, if there's concern about an obstructive component, certainly fluid status is important. A lot of patients with HCM are preload dependent to maintain left ventricular output. And so certainly fluid boluses would be very helpful. Minimizing myocardial demand and minimizing the whole body's demand is helpful as well. So intubation if needed. I think I would probably just go ahead and intubate to decrease demand. Positive pressure ventilation with your intubation is going to help your LV eject as well.
Yeah, so I'm thinking a little bit about like the case where we're going to find ourselves in for transport is that the hospital is going to call us saying that they have a patient who came in by EMS, sort of with your whole lead in on this story, and then we have to go pick them up now and bring them back to Children's, because they'll be like, hey, so we had this kid arrest, this is the story, this is what happened, they're now intubated, can you come get them? And that's like kind of all the information we're sort of gonna get. I guess a quick question for you that I'm just thinking about off the top of my head is other like medication management that we should sort of be thinking about in this patient in terms of supporting hemodynamics. Is there like a go-to vasopressor that you would think of for this kind of a patient? Would you add on like a positive inotrope just to kind of be helping with contractility and things like that in a patient who's sort of unstable with this kind of history?
Yeah, that's a great question. When I think of inotropy in terms of like epi, norepi, dopa, things like that, it is really patient dependent. And my general rule would be, and I'll go through this at the end, my general rule would be to use the minimal amount possible. All inotropes are going to have a pro-arrhythmic effect, especially your epi and your norepi. So I think if it's needed to maintain blood pressures, that would be reasonable. I think I would lean towards something that would increase your contractility rather than something that would increase your systemic vascular resistance, right? If you think you have a heart that's kind of struggling to pump against some obstruction already, and you cause your peripheral vessels to clamp down, you could probably make that worse, right? And so positive inotropy, epi, I think you could go to, or dopa if you need for blood pressure. But again, I would use the minimal amount possible, really, in all of these situations. And I would go with fluid above all else. Okay, so same story, collapsed while playing sports. This is your EKG now. What do you guys think? Anything that jumps out?
Prolonged QT.
Yeah, perfect. It can be hard to see in some of these, but right here, right, very long QT interval. And this is a congenital, most cases, this is a congenital diagnosis, long QT syndrome. And it causes abnormal and prolonged cardiac repolarization. You get this R on T phenomenon, which is what causes the polymorphic BT or torsade. Torsade is really just a fancy way of saying polymorphic BT. And exercise increases his risk because as you shorten your R interval, there's a higher chance that the R is going to fall on top of the T wave. Right. So just a few examples. This is right. Patient, here's sinus rhythm with a long QT interval. here's this PVC that's falling on top of the T wave. And that's what precipitates the polymorphic VT. And so what, these two questions are kind of tied together. What do you guys know of other things that can cause a prolonged QT interval, say outside of congenital long QT syndrome?
Think about different
Ingestions,
medications.
medications.
Say that again, sorry.
Some ingestions and medications.
Yeah. So ingestions, medications are a major cause. And in a patient, for example, especially in a patient already with congenital long QT syndrome, ingestions can especially worsen them. The other thing I think about is abnormal electrolytes, especially in a patient already with congenital long QT syndrome. So if a patient with this, for example, undiagnosed has, for example, prolonged, an illness with prolonged diarrhea or something that caused the potassium to be low, that could also precipitate it. Okay, so in terms of management considerations, it's kind of along those things, right? Along those thoughts. In addition to kind of general resuscitation, it's avoiding anything that can prolong your QT interval. Your two primary antiarrhythmics that cause QT prolongation are sotalol and amiodarone. And so those would be absolutely contraindicated in this type of patient. And then just maintaining, good electrolyte control. All right, same story again about this CCG here. So this is known as the quote unquote silent killer, right? Because to me, the CCG looks normal. The P waves are a little peaked here, so maybe there's some right atrial enlargement, but it's pretty nonspecific. And overall, the EKG looks normal to me. And so this is often the classic presentation of catecholinergic polymorphic VT or CPVT. It's a defect. It's another channelopathy, a genetic defect in a mutation in the RYR2 gene. And the resting EKG is often normal. And CPVT is known as the quote unquote silent killer. And it's triggered by catecholamines, exercise, fever, severe agitation, anything that ramps up the adrenaline in your body. This is really one of those cases where epi and norepi is really contraindicated in these patients. It's just a schematic we can skip through. So this is the classic presentation of CPVT during the arrhythmia, right? So normally the EKG looks totally normal. Here you can see there's bidirectional VT. So if you look at lead 3, right, the PVC goes positive, negative, positive, negative, positive, negative, positive. So that bidirectional ventricular tachycardia is the classic arrhythmia in CPVT. And so knowing that your catecholamines are big issues, that informs what your management considerations are, right? So aggressive fever control, right? Totally reasonable to intubate and sedate. Really good sedation is important. And really minimizing epi and norepi. These are really almost contraindicated. And you have to have a little bit of an index of suspicion for this, right? So there's reports of, for example, patient arrests in the hospital, and you go down your arrest algorithm, which is compressions, shock, and boluses of epi, right? And you give your bolus of epi, or you shock, you get the patient into normal sinus rhythm, and then they just jump right back into VT again. And then you shock them back into sinus rhythm, and they, a minute later, they're back in VT. And so if that keeps happening, you have to have a high index of suspicion that your epi or your norepi is precipitating this, especially if you don't have a diagnosis for the patient, right? If the patient is a known, hypertrophic cardiomyopathy, that may be different. But if you don't have a diagnosis, or that CPVT is your diagnosis, then epi and norepi can be very dangerous. And you really, in these patients, for blood pressure and cardiac output, your go-tos are really going to be volume as much as possible, and tolerating a much lower blood pressure, mean arterial pressure, tolerating a lower blood pressure because you're not going to be giving epi-NRV and because you're going to be giving sedation that might lower it. And as long as, that's in those situations, intubation can be helpful because you want to minimize the body's demand for oxygen to tolerate the lower blood pressure. All right, last one. Oh, this is maybe a new case. This I think is a new case. So this is a 4-month-old, cough and congestion for 2 days. Today he has new onset fever to 102, which did not break with Tylenol. He's crying and fussy, then suddenly went limp and then started seizing. By the time EMS arrived, patient stopped seizing. The vitals were okay. And then we'll just jump straight to the ECG, just in the interest of time. This one is pretty hard to see, I think, for non-cardiologists. I'll just go to it. So in lead V1.
The Brugada?
Yeah, perfect. Yeah. I think Josh had said that. Yeah. So there's kind of a coved ST segment elevation, right? So this is not an RSR prime. This is ST segment elevation. And that can be a little hard to differentiate. But this is
the EKG for the CPVT. Was that an RSR prime in V1, 2, and 3?
Yes, perfect. Yeah. So this is RSR prime, right?
Yeah, or at least
RSR,
V1, V2.
and it comes back to baseline before you see this negative T wave, right?
Okay.
If you look at this one here, the Brugada, right? RS, but there's not that S prime where it comes to baseline and then it goes into your T wave. It kind of there's a straight line, right? A straight slope right into your T wave. And so this is classic for Brugada. It's another channelopathy, genetic defect that predisposes you polymorphic VT and VF. Risk is especially highest in times of fever, dehydration, stress. The classic presentation is a kid in fever who seizes, and the seizure is attributed to a febrile seizure, but in reality, it's Brugada syndrome. So for this one, management considerations would be aggressive fever control, fluid repletion, electrolytes, very similar to before. The interest of time, I'm going to skip through these slides and just go to the end. So this is my kind of general management approach to a suspected arrhythmia or an arrhythmia for what it's worth. So you guys know CPR supersedes all else. So if the patient is unstable, hypotensive, no pulse, poor pulse, you go down your CPR, PALS algorithm guidelines. On top of CPR, there's a lot of other questions, some of which may be specific to the patient, but in general, right? So fluids, I think it's totally reasonable, excellent to give fluids, may help the patient, and in the acute setting, fluids are unlikely to be harmful, right? Strict electrolyte control, right? So potassium level above 4, but not too high. Ionized calcium level above 1 or 1.2, magnesium level above 2. Antipyretics, always yes, aggressive fever control, especially in, for example, Brugada patients. We give Tylenol for fever control, but if that's not enough, sometimes you may need to cool the patient. You may need to give ibuprofen, right? So in the US, ibuprofen is not authorized for babies under 6 months of age. The baby has Brugada syndrome or is having arrhythmias at all, I would give ibuprofen in a 2-month-old or 1-month-old, right? That's more important, really. Inotropes, used with caution. They are all proarrhythmic. Only give really the bare minimum needed to maintain perfusion and blood pressure. Adenosine, we talked about, okay to try if the patient is stable and the rhythm is regular. Do not give adenosine in irregular rhythms. And then antiarrhythmics, specific to the diagnosis. But I do want to touch, on the PALS algorithm, which for a VT, I actually don't know, is lidocaine or amiodarone, does it recommend one over the other, or does it say use one of the two at this point?
One of the two at
PALS
this
calls them
point.
both equal.
Sorry,
PALS calls them both equal.
both equal. Okay. Yeah, so I would say I think every electrophysiologist and cardiologist I've met would prefer to use lidocaine over amiodarone. Amiodarone has a very, very, very negative inotropic effect and can really affect your heart function. Lidocaine can as well, but it's typically less common and less severe. The main thing with lidocaine to watch for is that it causes a decreased seizure threshold. And so, so in a patient with, history of seizures, that might be a consideration. But even still, lidocaine really is what we would all go to in our basket. I think the calling lidocaine and amiodarone equal is probably from literature in adults. But in kids, especially young babies whose hearts are very sensitive, we would all go with lidocaine. And that, I believe, is all I have. Any questions? Final questions?
For inotropy for these kind of arrhythmia prone patients, would you think of vasopressin for these patients?
If your issue is you need, to increase your SVR, your systemic vascular resistance, that may be a good option. But a lot of times, so vasopressin is really only going to increase your SVR and not going to have much effect on increasing contractility. And so in a lot of these patients where there's some decreased function post-arrest, you do probably need to reach for epi or dopamine to help with your contractility. But for example, maybe in a CPVT patient, right, the catecholaminergic polymorphic VT patient who maybe is in sepsis and has really dilated peripheral vasculature, and you want to avoid norepi, then vasopressin would, for example, be a good choice in that type of patient. All right. Well, if there are no other questions, thanks for having me. Hopefully, it was a little helpful.
No, this is great. Thanks so much for your time, Dr. Hahn.
Thank you very much.
All
Thank
right.
you. It was wonderful.
Thank you all. Take care.
All right. Thanks, Dr. Hong.